Hello everyone, I'm Vishak C. Carey, one of the infectious disease fellows at Wayne State University, and I'm thankful to Dr. Monday for having mentored me in this quality improvement project. The project is titled Evaluating the Process of Outpatient Parenteral Antibiotic Therapy, OPAT, through the Six Sigma approach. OPAT programs aim to facilitate early discharge and improve patient care. However, the rates of readmission are high. In centers, especially like ours, without a dedicated OPAT note or order which can be queried, tracking this process is difficult from a QI standpoint. So we aim to utilize a Six Sigma framework to evaluate our OPAT process and define opportunities for improvement in patient care. We did not have a systematic way to track our patients leaving on OPAT, and thus we had to screen all the Wayne State ID consults over a period of last 5 months to see how many patients were leaving on OPAT. Our primary outcome was to describe how many patients are leaving on OPAT and to report the incidence of an adverse event, which was a composite outcome, including either an emergency department visit or readmission within 30 days. We also evaluated the clinical characteristics of the patients as well as incidence of outpatient ID follow up and also looked at the completeness of our ID documentation in the sign off note. We defined complete documentation as that which included antibiotic dose, duration, stop date, and had an outpatient ID appointment scheduled. Throughout this data analysis period, we conducted a Six Sigma analysis involving various stakeholders, including ID attendings, ID fellows, ID clinic nurses, and case managers. And this was done by Dr. Monday or Dr. Carey, including process mapping, Ishikawa diagram, and 5-wise analysis. Our results showed that during the 5-month period, 11.3% of the patients left on OPAT, and over half of these patients had bone and joint or cardiac infections, as shown in Figure 2. 30% of the patients who were discharged on OPAT experienced an adverse event. But as shown in Table 1, demographics, infection type, hospital location, and discharge location did not differ between the groups who had an adverse event and the group which did not have an adverse event. The most important to note from that table was that OPAT patients who had no adverse events were more likely to have seen by us in the clinic after discharge. It reduced the adverse events rate drastically from 51% to 20%, which was statistically significant with a p-value of 0.039. Focus group analysis with various stakeholders revealed that the common assumptions which were not supported by data as shown in Figure 5. So the stakeholders said, we do not do much OPAT, but most of our patients go home, finish their antibiotic in the hospital. Well, that was not true. On an average, 10 patients were discharged on OPAT from the hospital in a month. They said that DRH patients are the ones who get readmitted. They said IV drug users are a problem, and those patients getting discharged on vancomycin get readmitted. Well, the adverse events did not differ based on any of these factors. They said we don't do home infusions. All our patients go to nursing homes. The discharge on home infusion was 40%, was as common as discharge to a subacute nursing care facility. They said they were confident that I always document and make a clinic appointment. Well, that was not true. Data showed that complete documentation was only seen in 50% of the patients. They said, even if I make an appointment, what is the point? They never show up. Well, that was not true. 63% of the patients do show up in the clinic if an appointment is made, and some additional patients even call to request an appointment. They said, oh, it's cumbersome to make an appointment. How does it make a difference if they come to see in my clinic or not? Well, it clearly showed that OPAT patients who had no adverse events were more likely to be seen by us in the clinic after discharge, and that reduced the adverse events rate from 51% to 20%. They said, I would go on to schedule them at the end of therapy. Why should I see them early? But if you look at the data, median time to adverse events were 12 days. That means that we have to see them earlier. So in conclusion, OPAT patients are complex and challenging to care for, with 30% experiencing an ED visit or a readmissions. And if they are seen in our clinic, they're less likely to have adverse events. So our OPAT process, the Six Sigma analysis, also revealed excessive heterogeneity between stakeholders' opinion and the data was significantly different. So major opportunities that we have identified for improving this process is standardizing the documentation through OPAT sign-off note and reducing scheduling heterogeneity by engaging ID physician assistant in that, and make a goal to see the patients in the ID clinic within 14 days, hoping that the OPAT process will improve. Thank you.